All right. So welcome to NAMI New York State's Lunch and Learn series for May 2026. Uh, Today we are focusing on the New York Health Act. We started these policy lunch and learns to help our members kind of understand policy issues and areas and some occasionally bills more broadly, as well as to understand the systems of New York State that are currently around us and how to better advocate for them. With that, we will turn over to our speaker, Steve Rabinu-
Rabinowitz.
Rabinowitz,
That's okay.
who lives in White Plains, New York, retired at the end of 2016 after 30 years of service in the New York State OASIS, Office of Addiction Services and Supports, and spent the last 12 years director of downstate field operations, overseeing funding programs, services in NYC and Long Island. Since then, he's been a consultant and aspiring addiction treatment providers in the areas of certification, compliance, budgeting, programming, community relations, and service to older adults. Also serves on the board of the Greater Mental Health of New York and the New York Psychotherapy and Counseling Center. And they'll be speaking. He will be speaking today on the New York Health Act.
Great. Okay, well, thank you. This is great. Great to see everyone here today. And if you could go ahead and, yeah, James is going to be running the slides for me. Okay, so as James told you, I am here from beautiful White Plains, New York, and come to talk to you on behalf of the Campaign for New York Health, which I'm an active member of, and talk to you about the New York Health Act. So let's go next. All right, these are the items we'll be talking about today: the state of healthcare, how the New York Health Act works, who's this going to help, where are we, how you can help. And of course, time for questions. Next. And we're going to talk about our current healthcare system. Okay, I think this should not be a surprise to anybody, but as you know, New York State does spend more than any other country in the world as a percentage of its gross domestic product. And you can see from the chart. And this only goes, excuse me, through 2023. So that trend just continues. But what are we getting for it is the big question. Next. And unfortunately, we see the United States, way down on the chart in terms of shortest lives, most avoidable deaths. Particularly, I know of interest to folks on this is the whole issue of premature death among people with serious mental illness, related to the side effects of many of the psychiatric medications they're taking. And so far, our relative inability to make that better. Next. And the U.S., there are things we do better than a lot of people, but one thing we don't do better than pretty much any country in the world is healthcare. We're really the only high-income country in the world, and you can see from the lineup. And by the way, with these slides, James will be happy to share these with everyone, all of you, so you can look at this in some more depth later on. But you can see that every other country in the world is providing some manner of universal healthcare, whether it's voluntary or through government sources. Next. And as a result, we have a country where we have 740,000 New York people in New York State alone. Medical debt. Medical debt is the primary cause for personal bankruptcy, pretty much throughout the United States. 45% one or more cost-related barriers, and the overwhelming majority of people very concerned or worried about how they're going to be able to afford their health care in the future. That's next. And on top of all that, as if it weren't bad enough, we now have the problem of the various federal attacks against New York City, the $13.5 billion in healthcare costs. New Yorkers losing coverage, whether it's the a significant reduction of the essential plan or others, people being forced into more traditional Medicaid, which will provide them the coverage, but happens at great cost, and certainly significant job losses as well. Next. And we see particularly, and I'm sure some of you are coming in from rural areas of upstate New York. One advantage of having worked for the state for 30 years, I got to know the geography of the state quite well. But I also know that in many of the places where I'm sure some of you live, you're already having to travel significant distances for get your basic health care and certainly for any hospital care. And we don't expect that with the federal cuts that's going to get any better. Longer wait times and and skyrocketing premiums as well. Let's get next. Okay, we've got a blank slide here. Next. Oh no, here we go. And one of the things that we know, and I think certainly people who are dealing with mental health and substance use issues know is that the tremendous health disparities in our system, poorer health outcomes, higher suicide rates, the move to privatize Medicare or Medicare Advantage or Medicare Disadvantage. As someone once pointed out, a great program as long as you never get sick. High maternal mortality, which the state is trying to address, but a wide range of problems and health disparities in a system that costs more per capita than anywhere else in the world. Next. And pure and simple, our healthcare system, our current health system, it maximizes profits over the health of New Yorkers. And health is way too expensive for the majority of New Yorkers, and many are being driven into debt as a result. And the answer, yeah, that's a yes, we will be sharing the slides. Next. So now with the OBBA, which is going to double the population of uninsured individuals, that means greater burdens because hospitals, people are going into emergency rooms instead of primary care for their health care, much more expensive, and the burden ultimately winds up on the taxpayers, and healthcare costs are skyrocketing for New Yorkers. Next. But what's the solution? Well, we believe the solution is the New York Health Act. And let's go next. We'll start telling you about what that's about. New York Health Act is essentially a bill. You'll see it's been around for over 20 years, where we've proposed to provide high quality, comprehensive health care for every New Yorker, everybody in and no one out, covering money, a very wide range of services, not only those currently covered by Medicaid, but vision, hearing, and long-term care. And with basically to eliminate premiums, copays, deductibles, and prescription costs. Next. Cutting waste. New York, excuse me, the United States and New York is certainly as well, besides having the most expensive health care per capita, also has the high, and maybe a lot of what drives that is the incredibly high amount of money that percentage of the healthcare spending that goes to administrative costs, and not to direct care, whether it's the money that the insurance companies take out. I remember in Medicaid managed care, typically that was 11% of their revenue went to administration and profit, even or whatever executive salaries for nonprofits, and the tremendous amount of money that's spent by healthcare providers, and particularly ones I'm the most familiar with, people who provide mental health and addiction services. The monies that are spent to do the billing, deal with the denials, deal with the rebills when they have to happen, the medical justification for claims and so forth. Figure roughly 20% of current healthcare spending is going to administrative costs and essentially wasted. The Medicare system, by the way, operates at about 3% administrative costs, and the New York Health Act aims to create a system where we're operating much more like Medicare than the current system. And thousands of lives saved each year because not only will people get the care they need when they're ill, but we will really have a much ability to do a lot more with preventive care. Next. And this is an array of the services that the New York Health Act proposes to provide. The one thing it doesn't do is limit to in-network doctors and hospitals. Basically, if you're a healthcare provider in New York State, you will get paid by the New York Health Act. All the things that the current system does not do with regard to copays, premiums, deductibles, guarantees, prescription coverage, and the most important point, which is one of the mythologies that gets put forward about universal health care, is that you will see the doctor that you choose. Next. So how's it going to work? Next. All right. Well, the current system, if you see the convoluted thing, you pay for health insurance, you get sick, you go to an in-network doctor, you pay a copay, you pay additional copays, you try to get approved. New York Health Act is very simple. You get sick, you go to the doctor, you get the treatment, doctor sends a bill, and that's to the New York Health Fund, and that's it. Next. So, how will we pay for it? Also, one of the mythologies that gets put forward. People say, "Well, we're going to raise taxes." Yes, there will be a progressive tax that will go to pay for healthcare costs, but in lieu of uh, that's in lieu of premiums, deductibles, and copays, and the thousands of dollars each year that many people pay, even if you're staying in network. Never mind what happens if you really need to or really want to see a doctor who's out of network for your current provider, and all the situations where people feel like they have to change their insurance providers because of who's in network and who isn't. And folks know that it was just a couple of years ago, the New York State Attorney General Letitia James and her staff did a report where they found that a lot of the networks that managed care organizations and such were claiming to have, um, particularly when it came to things like behavioral health or mental health and addiction care, were essentially fictive. And that you say, oh, we've got 20 providers who do outpatient mental health care. Well, you call up those 20 providers and say, oh, well, no, we're not in that plan anymore. Oh, we really don't do that. And maybe all of a sudden that 20 went down to three. And there's been just a constant need for state officials to regulate and oversee that situation. And what we have with the New York Health Act would be a universal care, so that no longer becomes an issue. Next. We won't spend a lot of time in the weeds here, but you'll see, all the places where we the types of savings, good portion of it reduced administrative costs for insurance, getting rid of provider administrative costs, reduced drug prices. New York State's ability to negotiate reduced drug prices when you're bargaining for 18 million New Yorkers, as opposed to each individual insurer, provider agent entity trying to bargain, it becomes tremendous. If you look at comparative prices of pharmaceuticals around the world, someone I know who's also been very active in the New York Health Act is from Sweden originally, and I forget which medication, one of the very standard arthritis medications. Whenever she's in Sweden, maybe once a year, she stocks up because she can pay something like 5 cents a pill for something that costs $5 a pill here. Yet somehow the pharmaceutical companies can still sell it and make a profit at 5 cents a pill. Which tells you where is that money going? And some of the additional costs that will come with it, there will be some costs because we're going to cover everybody, improving provider fees, picking up long-term care. But even with those additional costs, we still have potentially savings as much as $63 billion. There are some reports coming out, one actually coming out Monday of next week. There'll be a major press conference in Albany, and I see we're joined by my colleague and friend Ashley Fox, who's also very active in the Capital District on New York Health Act, as part of that, and be rolling out reports on the potential savings to county and municipalities for their own workforce with regard to New York Health, but not to mention, dealing with their current shares of the Medicaid spend. There's also another major report in the work. This cites some reports, the RAND report, which is well known, that was several years old, and some recent updated analysis, later updated analysis, but some very new information coming out probably within the next month that shows updates to these figures, and if anything, shows this or even additional savings from the New York Health Act. So in the long run, there's no question that billions and billions of dollars that we're currently spending in New York State alone on healthcare would be saved, and as a result, get significantly better and universal healthcare for all parties concerned. Next. Who does it help? Majority of New Yorkers. Many people will save thousands of dollars a year and never have to worry about receiving care ever again. I was working for the state of New York. I was fortunate in some respects. We had a very good, and still do, as a retiree, have a very good healthcare system compared to what else is out there. But it didn't come free. Um, I paid, my family paid a significant portion and still do. And certainly, you all as taxpayers paid a lot of it, paid a lot of that bill as well. And not because you necessarily, and not based on whether your wealth or income, but just based on the fact that you were New Yorkers. So we, again, by moving into a progressive tax system, we want to put the burden where it really belongs on those who are the most privileged and have the most ability to pay. Next. So yeah, a lot of older adults, like people like me, look at this and don't know as much about the bill. Say, well, what do I need? I've got Medicare, it's fine. But the fact is, it's a significant upgrade to Medicare because we'll be talking about covering things like vision, dental, prescriptions. We get rid of the issues. My family and I just dealt with this, is things like concern about lookbacks. If you're a older adult and you facing the prospect at some point you might need to, spend down and go on Medicaid. You look at the risk of losing your home, or having a lien, losing your children and grandchildren losing the inheritance that you worked for your whole life. This bill basically eliminates that risk. Next. Um, LGBTQ plus community, and I have a son who is very active in the gay community, are insured at much higher rates compared to the rest of the population. The New York Health Act eliminates those inequities and provides every individual with comprehensive care. Next. And we were talking about this earlier, safety net in rural hospitals. Certainly, if you're in an urban area, and many cases you rely on, even if it's not your regular hospital, you're in an accident, you wind up in a safety net hospital. We know that those hospitals are tremendously challenged under the current funding system. And as we mentioned earlier, rural hospitals and healthcare providers tremendously challenged. We've seen lots of closings going on, people having to travel further and further just to get basic health care. And by virtue of having a universal system, we can not only preserve what we have, but hopefully fill in some of the gaps and plug the holes in our existing healthcare system. Next. As we was just talking earlier about this a report that's coming out, yeah, about 10.5% of property taxes that of us who are homeowners pay is basically going to pay for the health benefits of our municipal and county employees. And the share of Medicaid costs is a good large part of our property taxes. And we can achieve a very significant property tax relief by shifting the burden of healthcare from premiums into a progressive tax system. Next. And where are we in terms of passing the bill? Next. All right, it was reintroduced in January of 2025 for this legislative session. As I mentioned, it's been around for a long time. The real champion for the New York Health Act was, and the found and its initiator was Assemblyman Richard Gottfried from Manhattan. Retired a couple of years ago, but still out there and still active. Just saw him at Lobby Day a couple of months ago. And Dick is still out there fighting the good fight for this. Next. Okay. Um, what we hope to do with this presentation today and doing similar presentations all over the place. Just a couple of weeks ago, I did one for the local Rotary Club, and we're really looking to try to educate people. One of the things we found in the campaign is that just still a lot of folks don't know about the New York Health Act and what it is and what it proposes to do. But the minute you start to talk to them, we just did some tabling at a local farmer market the other day. And as soon as you mentioned the idea of universal health care, they said, oh, that sounds good, sign me up. We know that recent polling has shown that somewhere north of 60% of New Yorkers support the idea. Once I explained to them, support the idea of the New York Health Act. And we think that Just as people continue to get educated and aware, that number, if anything, will just increase, particularly given the kind of crisis we're seeing in healthcare now. But of course, our major part is to get constituents and folks, like yourselves, if you're uh, you know, support this bill to put some pressure on legislators to go ahead and try to get it passed and finally bring universal health care to New York State. Ultimately, our goal, of course, is to get it to the entire nation, but we think that New York State can be a very powerful model for the rest of the country if we can successfully implement the universal health care system. Next. What stands in the way? Well, big money. Surprise, surprise. We've got the insurance industry that has billions of dollars at stake here. The pharmaceutical industry, which makes a lot of money off the current system. Um, Definitely looking to probably push that. Unfortunately, there's a significant lack of awareness, but that's something we're working on and political pressure on the legislature. As the legislature has still not passed the budget for this year, as you know, though I'm hearing that probably voting on that starts, she'll be happening next week. So hopefully by the end of next week, we will have an enacted budget in place. But, New York State is, like many places, dealing with all manner of issues, immigration concerns loom very large um, public education, you name it. So sometimes it's hard to get something like this onto the radar screen of the policymakers, but that's what we're working to do. Next, how can you help? One, we'd love to see people, your individual organizations, or of course, love to have NAMI or other groups that you might belong with come on, sign on board. There are hundreds of organizations from the League of Women Voters to so a couple of unions and civic, social justice groups and so forth. One of the approaches we're going to be doing with the rollout of this report on county municipal savings is trying to get our counties and municipalities to also pass resolutions and sign on and endorse the New York Health Act. And we think that'll be a strong way to bring pressure onto the elected officials to, move the bill forward. Next. We have the collective power for change, and we've seen that in so many areas that we over the recent years that um, by organizing, putting public pressure, getting people to volunteer to be work on the bill, raise some money to get the message out. We're fighting some very big opponents in terms of big money and very entrenched reasons for wanting to push back on this bill. But we think that people together can and have made tremendous changes in the world, and this is certainly one area I think this can happen. The other countries that have um, universal health care, Canada being the closest one. Canada originally started with one provincial leader in one province, a man named Tommy Thompson, who's now considered the most admired person in Canada for many years running, because he brought them the universal health care by starting, I believe it was Saskatchewan, and then rolling it out to other provinces and eventually became a national law. And I know there's a lot of mythologies out there about Canadians and what kind of healthcare they get, but you never hear of someone moving from Canada to the United States who says, "Gee, I want to move to the United States because I want to take advantage of their wonderful healthcare system." That doesn't happen, and we see that universal healthcare takes different forms in different countries. In many, some countries like Britain, it's actually the healthcare system is not entirely, but largely operated by the government itself. That's not what we're looking to do here. It's basically think of New York Health Act as Medicare for all, or I should say an enhanced Medicare for all. It's Medicare for all, but bringing in provisions and services that don't exist in Medicare currently. Next. Okay, well, we got through that pretty quickly. So I want to open the floor up, questions and comments, discussion. Love to hear from you if you have any things you're not sure about, and certainly to any thoughts you want to share would be great. Pass, go ahead. Rena, I'm sorry, go ahead.
You should be able
Yeah.
to unmute yourselves now, but you do need to unmute.
Okay. I'm just curious, what do we do about the buy-in for providers?
That's oh well, and we are joined by our real hero from the New York Health Act, Dick Godfrey. Dick, great to see you. Maybe Dick, you want to take a flyer on that one?
Well, it's interesting. We've got support from the state chapters of the pediatricians and the family practitioners. I believe it's the New York, the Brooklyn chapter of the Medical Society supports the bill. The reason I was a little late joining this meeting is I was on a Zoom meeting with the New York chapter of the American College of Physicians, which represents the internal medicine physicians. Nationally, they support universal health coverage. And from the sound of my meeting with them, it sounds to me like the New York chapter is going to endorse the bill. So on the physician side, we're making progress. Um, there are some people in the hospital community who strongly support the bill. Um, Mitchell Katz, who is the longtime president of the New York City Health and Hospitals Corporation, through several mayors, has long supported the bill and continues to. Uh, my sense is that healthcare providers are just antsy about it. The notion of one payer being in charge of the system makes them kind of nervous. Um, uh, I think what I have said to them is, first of all, the bill has language in it empowering hospitals and other providers to collectively negotiate with the New York health system, which you can't do today. Um, and I remind them that, up until 30 years ago, not many people remember this, New York State regulated what insurance companies paid to hospitals. And the hospitals actually loved that system. Why? Because the members of the legislature all wanted to take good care of their local hospital. What a surprise. Uh, and what killed the system in 1996 was when it was up for renewal, uh, Governor Pataki, listening to the insurance industry, said to the legislature, don't bother passing a bill renewing the system because whatever it says, I'm going to veto it. And that was the end of that. Uh, and the legislature is going to treat our hospitals very well, and we're going to treat our doctors very well, uh, because we want them to be there to take care of us and our constituents.
Thank you, Dick.
So
And you think we'll
I
remember
think, yeah, a lot of providers are nervous, but I think ultimately they're going to do very well with the New York Health Act.
Yeah. And I'll just add to that, James, I see your hand up, but let me just add to that. And Dick will remember this, is that when Local 1199 began really organizing among hospital workers, in fact, the was 1199 and groups like Greater Hospital Association, New York Greater Hospital Association, Greater New York Hospital Association, beg your pardon, would actually be able to come to the legislature and talk about, well, we need X amount of money in terms of making sure we pay our employees the kind of salaries they deserve. And that got negotiated out. But as a result, New York actually has some of the better paid, if we compare to many other states. Hospital workers do much better here, and rightfully so. Now, I'm prejudiced. I have a daughter who's a nurse in an ICU. But the fact is that having this system basically ensures that, you know, providers and employees and everyone in the community can work together with the legislature to make sure that our hospitals and healthcare provider agencies are adequately funded to do the work they need to do. James, go ahead.
So that was actually one of the questions I had prepared for this event, because one of our bills is sponsored by the two mental health chairs and has to do with youth mental health reimbursement rates. It wants to make the Medicaid reimbursement rates, since most youth are on CHIPS, Child Health Insurance Plus. It's trying to make 130% the Medicaid rate for youth mental health services. The reimbursement rates have been so low that most programs can't afford to function, and to the point where New York State recently settled the lawsuit around whether or not they were violating Americans with Disabilities Act law and the I apologize, I'm forgetting the name of the federal law. It starts with a W. But the bill that says it's least restrictive means. So essentially forcing youth into inpatient programs. So what would the recourse be if the state was not reimbursing enough, since it's the only payer?
Well, the bill language begins with an explicit legislative finding that Medicare and Medicaid payment rates do not meet the standards of the bill, which they don't. And the standards are spelled out in the bill. And under the New York Health Act, New York Health would pay providers under Medicare an extra payment on top of what Medicare pays them, and the same with Medicaid. And so the inadequate payments that they now live with under Medicare and Medicaid would be remedied by the New York Health Act. You know, under the hospital reimbursement regulatory system that I just talked about, the rate that the Blue Cross folks paid for, you know, a given healthcare procedure was statutorily linked to the same rate that Medicaid paid for that procedure. And as a result, Medicaid paid hospitals quite fairly. And as soon as that system ended, that's when the Medicaid rates fell to the floor and separated from insurance rates. Under the New York Health Act, that linkage would be restored. And, you know, my appendectomy would be worth the same to a New York hospital as the poorest New Yorker's appendectomy, and the governor's appendectomy, and the governor's family's appendectomy. And believe me, the members of the legislature and the governor are going to make sure that they and their families are well taken care of, and all 20 million of us will benefit in the process.
Right. You know, one of the principles you have to consider here is that, you know, as the current healthcare system goes, you know, it's heavily, the decisions are made in corporate offices, whether it's the large hospitals, the insurance companies, pharma and so forth. And by having a universal public healthcare system, publicly funded healthcare system, you know, we basically give power to the voters to instruct their legislators about how they want to see the system run, and we have the ability as voters to help, you know, influence those decisions or help make those decisions, as opposed to the current system where at best what we can do is use regulatory mechanisms, but they're often not nearly strong enough, and many times the providers will just defy them. A recent example is in mental health and addiction care, the regulation that insurance companies have to reimburse at minimum at the what's called the APG, which is basically the rates that Medicaid uses for paying for mental health and addiction counseling and treatment and so forth. I do consulting work with provider agencies, and they say still there is still plenty of the insurers who are refusing to pay. Eventually, yes, the State Department of Financial Services and everyone else will get after them, and they'll force them to pay it, but they'll delay that as long as they can. And it puts the burden back on the providers of care to spend their very valuable time instead of providing direct care, fighting with insurance companies to simply obey the regulations that are in place.
Yeah, I know for another one of our bills that has a lot to do with the prior authorizations,
Mhm.
both the clawbacks as well as continuous prior authorizations. I do want to get to another question in the chat. Someone asked, do we have any estimates on tax brackets on how much an individual would pay? So let's just say median household income tax bracket. How much would they expect to pay?
Dick, you're probably a little more knowledgeable on that than I am.
Yeah, the bill, of course, does not specify what the brackets and rates would be, except to say that the first 25,000 of anyone's income would be taxed at zero, and the first $50,000 of your income, if you're a Medicare enrollee, would be exempt from the tax. Basically, in reflecting the fact that by being on Medicare, you're bringing, a big chunk of federal money into the New York healthcare economy. We couldn't really spell out the brackets and rates in the bill now because the bill won't take effect and be implemented for probably 2 or 3 years from whenever it's passed. And nobody today knows what incomes will be down the road, or what the cost of a broken arm will be down the road. But there have been several independent professional analyses of the New York Health Act, of other state proposals that are similar, and of national proposals by consultant firms like the Rand Corporation and by academics. And they all demonstrate very clearly that thanks to the savings that come with the New York Health Act, almost every New Yorker will spend less on New York Health Act taxes than they now spend on health care and coverage. And so while a broken arm will cost more 5 years from now, incomes will be more 5 years from now. What we know is that based on today's incomes and today's healthcare costs, you would have these enormous savings, and that won't change going down the road.
Sure. And my apologies because I think James got the version of the slideshow that was missing 2 slides on behavioral health, but I'll just tell you what they said is that, and I'll make sure you get the updated version of that. New York State currently, the spend on mental health and addiction care is about $14 billion. So think about reducing that even 10%, and probably we're looking at more. That's $1.4 billion in cost in resources that we free up for things like community-based clinic services, residential respite care, crisis care, medication-assisted treatment for addiction, and so forth. I saw you had the question about Olmstead, and one of the things you think about is that one of the problems, I can't say I'm an expert on Olmstead, but I know something about it. And the problem about people being in the least restrictive level of care is the availability of that care. And by freeing up the kind of money that the behavioral health system alone allows us to provide, who knows, maybe 200,000 more clinic slots, or I don't know how many thousands of residential beds, supportive housing units, you name it. And we think that the New York Health Act will get us to a place where we really can do least restrictive care for people who are in need of care.
I saw Pam, you had your hand up.
One thing about insurance companies, if you go to a restaurant and you order something with your favorite vegetable, and they give you a really tiny portion of your favorite vegetable, you're probably not going back to that restaurant. And if you go to XYZ insurance company and you want coverage for mental health care, and they only cover, they pay, like zilch. And as a result, the provider that you want to go to is not covered by that plan, you're probably going to go, you'd like to go to some other insurance company for coverage. What does the insurance company think about that? Well, they say, oh, somebody who wanted to spend a lot of our money is unhappy and they're going to go to our competitor. That's a good thing. Restaurants hate it when they lose a customer who wants more of that vegetable. Insurance companies love it when they lose a customer who wants more of the care that the insurance company doesn't want to provide. Insurance companies don't make money providing mental health care. Insurance companies make money collecting premiums and not providing mental health care.
So, Pam.
I have a separate question. I have read, and I don't know if it's true or not, that Hochul does not support this bill and would also be on the side of insurers. I have no idea if there's any truth, but what do we know about support from Hochul?
We don't know. And, you know, I served in the legislature for a long time under 9 governors. Every one of them, if there was a bill like the New York Health Act or something bigger, something smaller, and if it wasn't their bill and you asked them whether they supported it, in almost every case, they would say, well, you know, if it gets on my desk, I'll think about it then. I guess they teach you to say that when you go to governor's school. So, yeah, I don't think Governor Hochul has spoken on this topic.
And,
Thank
you know, the political reality is this is, 2026 and it's a gubernatorial election year. Things may be different by next year. We don't know.
Right. There are also, sorry, 4 questions in the chat that I think.
I was just looking at those. Thank you for pointing those
thank
out. Yes. So let's see. Scott had a question. What are the downsides of the act? I have relatives who experience Canadian, UK universal health care and have had issues with wait times and choice. Well, Scott, I mean, first of all, in terms of the UK, that's largely done through the National Health Service, and this model doesn't, entail that at all. We're not looking to, for a government-run healthcare system. In terms of Canada, I don't dig. I hear varying things. I think that many people will say that, there can be wait times for certain things. By the way, there are plenty of wait times here in the United States, depending on what kind of resources you have. People talk about rationing. In fact, we have rationing based on, how much money you got, to a large extent. Dick, what's your reaction to that one?
Yeah, well, a few things. One is that for Canadians, their system of health coverage is the most popular thing that their government does. And the notion that somehow there will be long waits for care in Canada is largely mythical, number one. Number two, part of the problem with delivering healthcare in Canada is that it's a country with a population about the size of California, spread out over a territory about 2 or 3 times the area of the United States. And when a healthcare system is, when the population is spread out so thinly, making sure that every little town and village can provide heart surgery or knee replacement surgery is just not going to work. And interestingly, in America, who are the people who need the most knee surgery? It's not young people. It's people who are covered by, guess what? Our publicly funded health plan, Medicare. And seniors love the Medicare program. And the New York Health Act, the strongest guarantee of quality of care will be that the governor and every member of the legislature and their families, their friends, their staffs, their campaign contributors will all be covered by the New York Health Act. They will have a powerful vested interest in making sure that it treats us and that it treats them and their healthcare providers as well as can be. and 20 million of the rest of us get to be part of the same plan. And the language in the bill guarantees that healthcare providers will be well paid. And the all in the same boat phenomenon is also a powerful guarantee that our healthcare providers will be well taken care of and will take good care of us.
You know, Scott has some other questions, but I see Lillian has and James have their hand up. Why don't we take Lillian's and we'll go back to Scott. Having trouble hearing you, Lillian. My apology.
Lillian, you need to unmute.
Muted? No.
I think she's muted.
Yeah, I think I heard something else, but maybe some background noise from someone else.
Move on to the next person. Go to
You'll
the
do
next
that.
one.
Okay, yeah. So let's go back to Scott's second question was,
Now
and then we'll go to James.
I can you hear me now?
Yeah, we can hear
Yes.
you.
Yes.
Lillian. Great. Thank you.
Great. Okay. One question is that it was introduced into the New York State Legislature in 2025. Where does it stand right now?
It is in committee in both houses, where it has been for quite a while. It is co-sponsored by a majority of the members of both houses of the legislature. So if the legislative leaders let it come to the floor, it will pass overwhelmingly.
Oh. Right. Okay. And one thing about Hochul, I know that New York Progressive Action Network, at the end of September, they had an event in New York City. And the purpose of the event was to introduce the city to the New York Health Act, those people that might not know about it. And also a letter was delivered, hand delivered to Governor Hochul. And her response was that and this is what I've heard back from people that were there in the room when she got the letter. She felt that it was there was something hostile. She felt it was showed hostility. So I suspect that if this passed and was on her desk and she understood that there were so many people behind it, she might not feel that way. She might be more prone. Like we even said, call it Hochul care, call it whatever we can do to get her to sign it. So I think, our job is to get it in front of her, to have it pass. And that's what we all.
Absolutely.
Yeah, thank you, Lillian. That's great. Let me just go back to one of James' questions. Does any other state have a similar bill or state health plan to show success for partnership? Unfortunately, now both California and Vermont took a run at it. I think they both got to the threshold of enacting it, and for a variety of reasons changed. And I know there's been conversation in Colorado too. Dick, any others that I'm not aware of or didn't mention?
Well, those states have the same kind of political opposition to the bill that we see in New York. The Vermont story, about in around 2011, I guess it was, or so, they were on the verge of passing a single payer bill, and at the last minute, their governor, Governor Shumlin, who had supported the bill, pulled the plug on it. There were really, I think, two basic reasons why he got cold feet at the end. One was the way their bill was structured. It would not function at all unless there was federal approval of the plan. And he was wary of enacting a system that would be dependent on federal approval. The New York Health Act is structured very deliberately so that it does not require any federal approval. And secondly, their proposed tax structure was not really progressively graduated like the New York Health Act. And as a result, average Vermonters would have paid a much higher tax rate than they would have if the tax system was progressively graduated. Put that all together, and Governor Shumlin just backed away from it.
Last question of Scott, and then I'm going to go to James. But he said, "Do you have a marketing team budget for awareness exposure?" You're kind of looking at it. This is the campaign operates with what Melanie DeRigo is our one full-time staff person, and Melanie does a great job. But a lot of our work is done by volunteers. Various constituent groups and member organizations contribute. Some of the materials, printing brochures and doing these type of presentations. Again, both Dick and I are very fortunate to have our New York State pensions to help keep us afloat. So we give us the opportunity to go out and do this kind of work. But it's really very much a grassroots effort.
Well,
We don't
I always try to
have the money
remember
that Big Pharma, the insurers have.
I always try to remember to thank the audience for paying the taxes that fund my pension. Um, but if as more groups come on board with the bill, that will encourage even more groups to come on board with the bill, because people don't want to put a lot of effort into a bill unless they think it's going somewhere. So part of our job is to build support for the bill so that more people will know that it's going somewhere. And by the way, that will help with the fundraising that we need to really get this over the finish line when people see that it's gaining steam.
Right. One of the major groups that's involved, I think the largest single group in the campaign for New York Health is Physicians for National Health Policy. So doctors do have a little bit of money they can keep. Also, we found that physicians make a very convincing case for universal health care. I know when we've done lobby days, a lot of our doctors, some of them being, young medical students and residents up till older retired doctors, come with their white coats on, and that has a very powerful influence when people see that there are physicians who are there because, first and foremost, because they want to see the people they care for, taken care of properly and getting the care that they need. Let's turn, James, you've had your hand up for a while. Go ahead.
Yeah. I mean, on that note, if you need EMT groups, that was something I also saw in a previous career, was EMT groups feeling very irked that responding as a firefighter, responding as an EMT, responding as a police officer, I only billed your HMO for one of those things. But to the actual submitted question, how would this work with Medicare, Medicaid, TRICARE, retirement benefits, all of the other integrated health and retirement systems that already exist?
Well, for Medicare, the New York Health Act would fill all the gaps that now exist in Medicare. So nobody will need Medigap coverage. Nobody will have trouble getting coverage for their prescription drugs under Medicare Part D, et cetera, because the New York Health Act will fill all those gaps. Similarly, the New York Health Act will pay healthcare providers who provide care under the Medicaid program. It will pay them more than they are now paid. Retirees who are New York residents will get full New York Health Act coverage, which will provide them with dramatically better health benefits than any retiree has today.
I think this person's question is, does the money from those programs empty into the New York Health Act single payer system, or do they have to operate in tandem?
Well, federal money under Medicare and Medicaid uh, the at the start, at least, unless the federal government chooses to act, Medicare and Medicaid will be separately funded, and the New York Health Act will pay providers on top of that. If the federal government is smart, which may be a contradiction in terms, but if the federal government is smart, they will send New York every month the money that they were going to pay in New York under Medicare and Medicaid. It'll go into the New York Health Act Trust Fund, and it will all be administered as one program. Either way, it will work just fine. Just like today, if I go to the doctor, Medicare pays part of the bill. My retiree health benefits pay part of the bill. There are computers that make that happen without any human intervention.
Right. So essentially, yes, Medicare, as it does for state retirees, and I think for a lot of other folks here who are retired, is that Medicare basically would function as your primary, and then, as they said, the remainder of the bill kicks over into the New York Health Act as opposed to an individual insurer, or Medigap coverage or whatever else you would have had in the past. I think Rena, you've had your hand up for a while too.
I would like to know how it's going to work with long-term care, whether in a facility or a community. And not only for older people, but also for people with disabilities.
Well, the New York Health Act will cover any long-term care that would today be covered by Medicaid. So that is home care, nursing home care, et cetera. And the New York Health Act will pay the bill. Simple as that. Federal money under Medicaid would pay a portion of it as it does today. And state Medicaid and the New York Health Act will pay on top of that.
Because the way it works now is people who have the funds pay up front until they become Medicaid eligible, unless they were Medicaid eligible initially.
Correct. That will end. No one will have to spend down to poverty in order to qualify for Medicaid to get long-term care. Every New Yorker will be entitled to long-term care, rich or poor.
And again, I'm thinking not only of nursing homes, but also home care, again, for either older people or people with serious disabilities that need a lot of assistance.
Home care is certainly covered, yes. Anything that is covered by Medicare, by Medicaid, by Child Health Plus, by the New York State insurance law, by any state or local government covering any of its employees or retirees. If any of those programs covers anything, the New York Health Act will cover it for all 20 million New Yorkers.
Yeah, and we'll have to. The one group that may be harmed by this, I suppose, would be the elder lawyers, because my wife and I just spent some money to have our house put into a irrevocable trust, so that if it comes to the point where one of us has to go on Medicaid, that my kids will get to inherit the house that we worked our whole lives to pay for. So. We'd like to see that happen. As much as I appreciate the work of elder lawyers, I'm sure there are other aspects of law they can find work in.
Yep.
Let's see. Anyone else?
We had one other pre-submitted question was around that transition. So what would it look like as we transition from the current system to the new system?
The bill has a 3-year implementation period built into it, so it does not, because the day the bill passes, everything changes at once. I think you can explain a little more detail about it.
Well, yeah, it's not a specific time frame spelled out in the bill, but
3 years.
There will have to be regulations made and probably additional technical amendments to laws, and providers given an opportunity to sign up. Once that is taken care of, the state health commissioner flips a switch and the New York Health Act starts paying for claims. You know, when we created the child health insurance plan, Child Health Plus, it took about a year to be implemented, but it was a wonderful program once it was created. Similarly, the New York Health Act. It's you know, for individuals, the transition will be really nothing. One day you.
I come here every week.
See-
And nobody, you're talking on the phone. You're not even eating.
Well, the people downstairs told me if I had to do this, I had to do it here in the cafeteria.
Oh, really?
Yeah.
Well, I won't come again. Thank you.
Okay.
It's outrageous. They said, come to the cafeteria and do it here.
Yes.
Wow. Sorry.
Hi. So I'm sorry, the question again was.
Just around the transition. what
Transition
it would look
period,
like as
yeah.
we-
Mechanisms, yeah.
You know, when I retired, one day I went to the doctor and gave them my insurance card. The next time I went to the doctor, I gave them my Medicare card and my insurance card.
Right.
That was the transition. And the
Yeah.
receptionist made a copy of my Medicare card, and that was that.
Yeah.
Pam,
I wonder how costs are managed. Would we have a negotiation of acceptable prices for certain medical procedures and for long-term care or hospital care? Would we negotiate that? And as a way of making sure that we don't get overbilled for expenses?
Well,
Does that make sense?
patients will not negotiate it because just like we don't negotiate prices today when we have health coverage, the New York health system will set the prices that it pays for a given procedure, as New York now does under Medicaid and under a variety of other programs, and as we used to do for hospital care. And you use the word negotiate, the bill explicitly allows groups of healthcare providers to collectively negotiate with the New York health system. And it provides a system of independent arbitration if they don't come to a negotiated agreement.
Thank you.
Yeah, and also it allows for instance, on one hand, we could do regional differences based on cost, but then when we look at the issue we were talking about earlier about rural hospitals and so forth, where we've had a hard time getting providers in, you know, maybe there's part of the negotiation is to provide some financial incentives to try to get more doctors, nurse practitioners, and so forth to relocate to those areas and provide care. So it's all part of a political process. But again, as I said earlier, it's a process in which we as, you know, voters and taxpayers can actually have a say as opposed to living at the whims of the happens in the corporate offices of the insurers and big pharma.
Yeah, and for example, teaching hospitals that hire interns and residents, you know, Medicare and Medicaid pay those hospitals extra because they bear that expense. So would the New York Health Act. And that's a, you know, a longstanding system in New York.
Mhm. Okay. Did I see Pam? Did you have a hand up, or is that from before?
That was the last question.
Okay, that's great. Thank you, Pam. Okay. Anyone else?
We'll go ahead and stop the recording now. Just allow folks to ask questions after the recording
By the way,
stops.
if anyone has questions after the meeting, email them into the group and they'll forward them to me and I'll respond.
Absolutely.